Geriatric Pharmacology. Geriatric Pharmacology considerations. There's the silver tsunami, which has already begun. That means that there's this tsunami, this huge wave of people that are coming into healthcare right now. Physiologic changes that happen in geriatric patients provide a unique situation with medications that are given. The geriatric population is at a high risk for polypharmacy, and pharmacokinetics can be quite different at times. Some adverse reactions can be worse, can be heightened, and be prolonged due to perhaps less protein content in the blood, less ability of the liver to filter out during the first pass effect, and the less ability of the kidneys and liver to get rid of the product itself. Pharmacodynamics, we look at the lack of affinity to receptor sites, age-related changes in the central nervous system, changes in the number of drug receptors often become lower, changes in the affinity of receptors to drugs, so sometimes that affinity or the likelihood of the two of them actually colliding, the drug and the receptor, become less because that key and key lock model just becomes a little bit worn out over time. Compensatory response to physiologic changes is decreased. Adherence and non-adherence. There can be a lot of different reasons why people adhere or don't adhere. Do not always assume that it is financial, but it often is. Sometimes it is because of the side effects that are suffered. With geriatric pharmacology, we must talk about hypnotics, things that make them sleep, things used for insomnia. Lower doses are all often used. Benzodiazepines are all often used. But things are used often in smaller doses, especially because of the decrease in kidney function. With geriatric pharmacology, we look at diuretics and antihypertensives. Hydrochlorothiazide is something that we use in lower dose. Non-pharmacologic methods are often used to reduce blood pressure. Calcium channel blockers, angiotensin converting inhibitors, and A2 blockers are often used, but you've got to remember, especially with those alpha blockers, as we're getting them up, they're at that huge risk for orthostatic hypotension. Alpha-1 blockers are used. There's all sorts of things that are used, and there are a lot of polypharmacy substances that end up being used for these reasons. Geriatric pharmacology, we do talk about cardiac glycosides. Again, digoxin we talked about earlier. It had that narrow therapeutic range of 0.5 to 2 nanograms per milliliter. There's that possibility of digitalis toxicity. So if you start reading about halos, yellow halos, and changes in eyesight and perception of what they're seeing, it's a huge deal. So with anticoagulants, there's a decrease in serum albumin. There's also sometimes a decrease in the body's production of platelets. For one reason or another, it's more likely to have certain diseases. It's not a natural process of aging, but it's more likely to have certain diseases that would propagate bleeding. And geriatric patients are more likely to be on Coumadin or other blood thinning agents. So we're checking their PT and INR. They are at risk for falls, a huge risk, often due to polypharmacy and the risk of bleeding if they did fall. Geriatric pharmacology, we do look at antibacterials, and some of the risks of antibiotics become more so as the person becomes older. Aminoglycosides, fluoroquinolones, and vancomycin often become more dangerous. There's more risk of, with those fluoroquinolones, the Achilles tendon rupture. We skip over gastrointestinal drugs because we've talked a little bit about those. Antidepressants, the side effects can be a little bit more pronounced. MAOIs are definitely not often prescribed for older adults, as they don't tolerate them very well. Opioids with geriatric patients are often lower doses unless they've been on them for a long time, whereby they can it can lead to a tolerance or a tachyphylaxis. It can result in some pretty severe hypotension and respiratory depression, so don't forget that. Health promotion in the elderly, we again look at adherence and non-adherence. So allow the patient and promote the patient to be as alert and as sharp as possible with clean eyeglasses. Make sure functional hearing aids are in place. Speak in tones clearly so the patient can hear. Face the patient when speaking. Treat the patient with respect. Expect that the patient can learn. Use large print and bright colors in teaching aids. Review all medications each visit. Encourage a simple dosing schedule. And with the onset of confusion, disorientation, suspect recently prescribed medications with recent and sudden confusion and disorientation. Encourage the patient to report if a new drug is not improving the condition or if they're experiencing intolerable side effects, and that communication is key. Now, the nursing process, assessment with that nursing process, common potential nursing diagnoses, ineffective health maintenance related to lack of transportation, so that lowered protein, and the lowered perfusion, non-adherence related to the lack of insurance. These can be nursing diagnoses that can be related to that.